Okay, so we're going to talk about infection, and this part, the first couple of things I'm going to talk about are in Bruner, and someone pointed out that the Bruner pages were wrong, but now they're correct. And so I corrected those sometime this afternoon, maybe 12-ish or 1-ish. Who did I email? Somebody should know when I did that. Anyway, know these things. These are important things that you'll probably have seen in ClinApps 1, and if you haven't, you probably will. You need to know these terms for the chain of infection. The reservoir is the place where the bacteria lives normally. So we have bacteria that live on us all of the time. Bacteria are probably currently living on inanimate objects. Inanimate objects are called fomite objects, F-O-M-I-T-E, in your book. And so when I turned that light switch on and off over there, I probably picked up a lot of bacteria on my hands because lots of people touch it. Lots of people sneezed in their hand and touched it. Somebody used the bathroom and didn't wash their hands and touched it. And so I've got lots of things going on. So that's where bacteria normally lives, is the reservoir. Now, once you have bacteria living somewhere, it has to exit that place and enter into a new habitat for infection. And so for this instance of turning the light switch on, it's on my hand, and I'm rubbing my nose, and then it enters in through the mucous membrane through direct contact. Or actually, that's indirect contact, rather. So direct contact would be if you have a wound, and I touch your wound, and it's got bacteria in it, and then maybe I touch my mucous membranes. But indirect is I touch the light switch that somebody else touched and transferred their germs all around. Okay, so mode of transmission, other than direct and indirect contact, there's types of other transmission that you need to be familiar with the terms. Droplet, airborne, and contact are terms that you use for isolation in nursing. And so you'll need to know how those bacteria are transmitted that way. So if it's airborne, it means it's in the air and it's floating around. It's got a very low density because it's able to float. You inhale it. Like tuberculosis would be one of those types of illnesses. Droplet means that it's got a heavier density. So when you sneeze, you have little droplets that sit on the table or whatever. And then you have contact. So it's usually not airborne, it's not expelled that way, but if you came in contact with it, you would get infected. And so we put a lot of patients on contact isolation in the hospital, so if we suspect they have a contagious illness, we'll wear gowns and gloves and whatever, and mask, and make sure that we're protecting ourselves from transmitting disease. If you're using airborne, you're using what's called a negative pressure room, and using special respirators to filter out those tiny, tiny little droplet or tiny, tiny little bacteria. So what does a negative pressure room mean?
When you open the door,
air pulls in. The air is being filtered out through a system to the outdoors, right? So you need to have, next is a portal of entry. You have to have a way to get into the body. Mucous membranes are a good way to get into a body. An open wound, things like that. A surgical wound would be a good way. So if you ever have a surgical patient who develops a fever, one of the things you need to think about is did that infection get in through the surgical wound? And then you need a susceptible victim. So what's a good victim to get sick? Immunocompromised, the very young, the very old, the very sick. Okay, so think about who is going to be easily contaminated. So can you see what kinds of questions I could ask you about on a quiz? You know, you have these 3 patients. Who's the most susceptible? I could give you varying ages, varying illnesses, that kind of thing. So think about that. So on your body, you have several lines of defense already. They're biochemical and they're mechanical. So your mechanical defenses are really, straightforward. You have cilia to help move things out. You have mucus to trap things and prevent it from getting in. Acids in your stomach. secretions from the genital areas. And then you have also some biochemical things like lysozymes, which are enzymes that break down bacteria before they get into our body and infect us. Okay, so here are the people who are most likely to be good hosts. So they have decreased host resistance. So when we say age, we're talking about very young and very old, right? What do I mean by immunodeficiency? What kinds of people are immunodeficient? Say that again.
Cancer patients,
Why are cancer patients immunodeficient?
because they're on immunosuppressants often, or
Okay, so patients who are taking immunosuppressants, so in cancer patients, if they're taking chemotherapy, it's wiping out all of their good cells and all of their bad cells. It's not discriminatory when you do chemotherapy. So they could have no innate immune system left. What other drugs might cause immunocompromised situation? What about corticosteroids or glucocorticoids? Have you heard about those yet? Endogenous steroids. Those can decrease your immunity. Any patient who's severely ill or has chronic disease, their immune system's already under attack a lot, and they just have a weaker system. Some terms to know, and I'm not going to put a lot of time into this, but you should know what incubation period means. That's your time of exposure to the time of symptoms. And your prodromal period is that time where you feel like you're getting sick, but you're not quite sick yet. Anybody feel prodromal right now? A couple people, right? Fever. What else? Let's think about local infection. So there's two kinds of infection, a local infection and a systemic infection. So what's a local infection? What does that mean? Okay, so you have an infection in a particular area with swelling. You said swelling? Pus. We call it purulent drainage because you can't say pus. What if you write down in a chart the patient has pussy drainage? What does that look like? It's bad. Purulent drainage is much more copacetic to say. Purulent. You'll never forget it. My instructor said that to me way back in the 90s, and I remember it. And I still say it every class because I'm like, Okay, so if it localized, it's warm, it's red, it's swollen. You have a bug bite, for instance, that that's an potential infection. A systemic infection, on the other hand, means it got into your bloodstream. So you started off maybe with a laceration on your arm, and you had that initial localized response, but your antibiotics didn't kill it in time or contain it in time. So then it got into your bloodstream, and you start getting systemic infections. So it goes from the body in my blood all the way around. I start feeling rotten all over. So when I start feeling rotten all over, what does that look like? How do I present? Pale, diaphoretic, fever, tachypnea, tachycardia. Okay, all of those things are signs of systemic infection. You want to note that blood pressure is normal with systemic infection. It becomes hypotensive or low and abnormal with septic shock. So sepsis or infection in and of itself will have a normal blood pressure with everything else going on. But when you get a low blood pressure along with all those symptoms, you're thinking shock. Septic shock is worse. Okay, so acute infection, you have your signs and symptoms. A chronic infection is when maybe you had an acute infection, you took some antibiotics, you started to feel better, but then you remained sick, right? So this could be a case of somebody who didn't take their whole dose of antibiotics, and they remain, subacute for a long period of time. Okay, subclinical. A lot of patients who might go to the health center here are probably subclinical. because they're not really acutely sick yet, but they don't feel well. They feel like something's going on in their body, but they don't quite have symptoms yet, right? You're almost sick. That's frustrating when you go to the doctor too soon, right? And then if you went the next day, you'd be really sick. You can't prevent it sometimes.
Is that different from prodromal?
Prodromal, you're starting to get symptoms.
So you haven't gotten symptoms yet for subclinical?
Right.
Okay.
So some people say they've been exposed to something, they are worried they might have something, they don't have symptoms yet. Bacteremia is when you have bacteria in your blood, but your body is fighting it and doing a decent job at it. Septicemia is when you have bacteria in your blood and your body's not being successful at fighting it, and the bacteria start reproducing in the bloodstream. And it's when that bacteria start reproducing in the bloodstream that it causes some problems with vasodilation, which causes that low blood pressure to happen, which indicates septic shock. Okay, so there's a balance there, and there's like a tipping point.
Can you repeat that?
Which part? All of it?
Causes
So for septicemia, the bacteria reproducing in the blood causes vasodilation. There's an enzyme it releases, and that vasodilation causes low blood pressure, and that's when septic shock starts to become present and apparent. Okay, so here are a couple of terms. SIRS is a term that we hear a lot now. It's systemic inflammatory response syndrome. So this is when your patient has signs of inflammation but not quite infection yet, or you don't know where the source of infection is. So these are the criteria. You need to have temperature greater than 100.4 or less than 96.8, pulse greater than 90, respirations greater than 20, and white blood cells greater than 12,000. The difference between SIRS and sepsis is whether or not you have a known or suspected infection. So SIRS, you come in, you've got all of these symptoms, but we can't, you don't have a cough, you don't look like you have pneumonia. You don't have a urinary tract infection. We don't know if you're infected yet. Question?
On the ClinApps, they said white blood cell count, and it was like 20 and then some letters. What do those letters represent? Like FIB or F something?
I'm not sure.
Maybe it wasn't F, but it was just like a 20 instead of having 12,000.
Okay. Yeah. So what would that be if you had to notate that without the thousands? I don't know. I will find out. So, but we do start to talk like that. We won't say white blood cells were 12,000. We won't say white blood cells were 12, knowing that everybody's talking in thousands. So she's probably getting you ready for that, but I don't know exactly how she worded it. Okay. All right, so sepsis means you think there's an infection. You've got a pretty good idea of where the source is. Systemic inflammatory response, they look sick, but you don't know where they're sick at. So difference there makes a difference in how you treat your patient. Microorganisms are kind of important to us because we have to know what we're dealing with so we know how to kill it. And so there's a couple of primary shapes, your cocci, your bacilli, spirochetes. So we'll talk a little bit about the cocci and the bacilli in this class, spirochetes. The only one I know of is syphilis or chlamydia or something. Yeah, I don't know. All right. What you want to know are some things that these these bacteria can have on them, like spores. So if a bacteria has a spore on it, it's an inanimate, dormant form of the bacteria that can live for a long time despite disinfection and despite heat. So if you have somebody who's got a bacterial infection where the bacteria has spores, good hand washing may not take care of it. Disinfecting in the normal ways may not take care of it. You may have to do some high-level things. So an example of a disease that has spores is anthrax. Anthrax. Or botulinum, botulism has spores as well. The shape of the bacteria become important to us when we get a culture from the lab. The first time the lab calls to report a blood culture or a urine culture, the 24-hour report will tell you cocci in chains, bacilli in chains, that kind of thing. That's an indicator of what kind of bacteria we're dealing with. And you're going to learn that gram-positive bacteria are generally the cocci, gram-negative bacteria generally bacilli, and that your antibiotics will work on one or the other type better, okay? So when we talk about getting a blood sample or we want to get a culture of something, does everybody know what I'm talking about? Relatively? Okay, so you get basically you take out some tubes of blood, they go in special bottles for blood culture, and it's got a medium in there that's going to grow something. The lab takes bits of that blood out basically and smears it and looks at it and sees what's growing, puts it on an agar plate. You could do the same thing for urine, and they're identifying this for you because you need to know. Your patient comes into the hospital and they're sick and they want treatment today. They don't want to wait 72 hours for the culture to grow completely, right? So we're going to do some initial things to the specimen to see what it is. So one of the first things we'll do is a gram stain, and that will tell us whether it's gram positive or gram negative. If it's gram negative, it has this outer membrane on it that's very difficult to penetrate with antibiotics. So we know it's a more virulent bacteria. If it's gram positive, it's probably part of our normal flora that has found a way to get into a normally sterile environment and cause an infection. Okay, we'll talk more about that in a second. All right. I need to get my notes because I feel like I'm not telling you something I wanted to tell you. Oh, yes. Okay, so a characteristic of anaerobic bacteria that I wanted to tell you I was forgetting about is that they often cause necrosis and abscesses. Anaerobic. They can cause abscesses and necrosis. And this is because they cause some problems with clotting factors causing thrombophlebitis. And they also start giving off a noxious gas from the endotoxins that are released when the outer membrane of the bacteria is penetrated. So you start having gas formation. So if you see something that's got purulent drainage, something that looks red and hot and swollen, it is most likely an anaerobic bacteria. Okay? All right. So for anaerobic bacteria,
like the part where the outer membrane and gases.
okay, so with this anaerobic bacteria, when we give them an antibiotic or give an antibiotic that's going to target that particular bacteria, it has this tough outer membrane on it. It's called polysaccharide, so it's coated with this polysaccharide lining. And when you penetrate that, it releases toxins called endotoxins that cause a thrombophlebitis in the area, or active vasoinflammation in the area. Okay. In addition, it causes a production of gases, and all of this together can cause purulent drainage, swelling, necrosis of tissue. Okay, so for aerobic bacteria, you're not going to have that problem with the endotoxin in the polysaccharide layer.
So you say they give off the endotoxin when the outer membrane is
Penetrated, yes.
So it's always a mechanism.
Yes, that's correct. Uh-oh. Actually, I don't want to talk about that. Touched a thing. Okay, so make sure moving forward you know the terms virulence and pathogenicity. So virulence refers to the degree of pathogenicity. And if it's a pathogen if it's able to cause disease. So there's some bacteria that live out there that don't cause disease in us, right? In that case, they have no pathogenicity. They become more virulent, or they're described as more virulent if they give off toxins, if they're highly mobile, if they can adhere to tissues very well, or if they can avoid host defenses. And so ways to have increased mobility is if they have flagella on them, right? They give off toxins if they are that anaerobic gram-negative and you penetrate that cell wall or the outer membrane and give off that endotoxin. Some bacteria have biofilm on them that makes them sticky so that they aggregate together. So bacteria stick to bacteria and bacteria stick to the tissue where they are causing infection. And if the bacteria can avoid the host defenses, it's more likely to be virulent. Question?
So for the, when you're saying like it gives off toxins, are you talking about aerobic or anaerobic?
Anaerobic.
Okay.
Good question. So how could a bacteria avoid host defenses?
I don't remember how it does it, but it comes off as like one of our own cells. Like it just not recognized, I guess.
Okay, so normal flora that just goes into a normally sterile environment is one way that can happen.
Phagocytes can't bind to it?
Say that again?
Phagocytes can't bind to it?
Right, so phagocytes can't bind to it and eat up the bacteria. Think about things that you do in healthcare that could bypass all of the defense mechanisms. What are things that we do? We put tubes in people, right? So if you put a tube down my throat, you could scratch my throat and cause bacteria to enter. Put a catheter in my urinary tract and into my bladder. My bladder is normally a sterile environment, and you tried to put that catheter in and using sterile technique, but maybe not, right? So think about the things that we do. What about just taking blood? You're poking through my protective skin into my bloodstream. If you haven't cleaned that off well, Staphylococcus that lives on my skin can get in my bloodstream, okay? So in the same way that we can get Staphylococcus in our bloodstream from a needle stick, if I was on my motorcycle and I crashed and I got road rash all over me, that would be the same kind of thing, right? My outer membrane of skin is broken down and bacteria can enter. We have a couple of new threats on the horizon. We've had the Ebola scare of last year, and we're still kind of watching for that. So you want to think about newly emerging diseases when you're thinking about your practice and taking care of patients. And you want to know this so that you know the questions to ask your patient. So in health assessment, you learned how to take a health history, right? where you ask your patient all kinds of things. And part of that should have included travel to areas outside of the United States. That's one of your clues that someone might be at risk for a newly emerging disease. If the United States starts to have a newly emerging disease, the Centers for Disease Control will put out some notifiers, and whatever parameters are associated with that disease, we would ask our patients. Okay? So make sure that you know that there are special things you need to take into consideration. We have some drug-resistant bacteria occurring with Staphylococcus and tuberculosis. And so these are special situations. We need to make sure that if you're taking care of a patient with one of these diseases, and you're also taking care of a patient down the hall who's had chemotherapy today, that you're not spreading the disease between the two of them, right? So how are you going to do that? The best thing you can do is wash your hands, and I heard that right here. Wash your hands. But you're using contact isolation, making sure you're following isolation procedures every time you walk in the room for everything, and making sure that you're using precautions for your immunocompromised patients. So just like you would use contact precautions if I had an infectious disease, if I didn't have any white blood cells to fight disease, you should still wear a gown, glove, and mask. We call that neutropenic precautions. So when you don't have enough neutrophils and you're neutropenic, we take special precautions so you don't get sick. Okay, so some of the tests that you might have to look at when someone has a suspected or known infection includes the culture and sensitivity. And so for the blood culture or urine culture, I already talked about, identifying the organism. The other half of that test is the sensitivity, and that's seeing what antibiotics kill that bacteria. And so what I commonly do on your exam is give you a culture report and a sensitivity report, and give you a question and ask you, should you call the doctor? Does this antibiotic work? Or what are you going to do? Okay, so the bacteria, you'll have to know how to look at the lab report and identify whether it is sensitive or not sensitive to a particular antibiotic. It's not particularly difficult, because actually the lab gives you this report that lists off 5 or 6 or 10 antibiotics, and it says Y or N, yes or no, right? So it's not particularly difficult. It's just a matter of doing it, and I want to get you in that habit of doing it, okay? We'll talk about the complete blood count. When you get a complete blood count, you get a measure of red blood cells and white blood cells. For infection, we're worried about white blood cells, which are called leukocytes. It's called leukocytosis when you have an excess number of leukocytes, right? Within the leukocyte numbers, we often get what's called a differential. So you'll see it, the doctor might order a CBC with differential. So if you have a differential, it breaks down within the white blood cells which ones are neutrophils and which ones are monocytes and which ones are eosinophils and which ones are basophils. And based on the predominant number of whatever kind of blood cell, you can help or you can make a good educated guess about what's going on with your patient. So if they have a lot of neutrophils, you think they probably have a bacterial infection. If they have a lot of eosinophils, you think they have an allergy to something. Okay? That kind of thing. So when you look at the white blood cell count and you see that they have a lot of neutrophils, which we call a left shift, which is a term that's used. If they have a lot of white blood cells, we think they have an infection. And if they have baby white blood cells or baby neutrophils called bands, we know they have a serious infection. The body is not only sent out a big troop of neutrophils to attack, it's already called forth a whole bunch of new troops to get ready to go. So it's producing more white blood cells to fight it. And just as a reminder again, when you have low neutrophil count, your patient is very high risk for getting infections. Okay? So you would take special precautions. Empiric therapy is a term that you all should probably know. There's a couple of terms. So prophylactic therapy is one and empiric therapy is another. And students sometimes mix those up. So empiric therapy is treatment based on the best evidence. So we know which pathogens affect which body systems typically. And we know typically which antibiotics affect which pathogens. And so we make a good educated guess. And so this is graphic right out of the Merck manual. And so the Merck manual is one of the gold standards. And so if you have a patient with a skin infection called cellulitis, it's typically a group A strep or a beta hemolytic strep or a Staph aureus. And based on the fact that we know these are the common bacteria, it tells us how to treat it. Okay, empiric, we're making a good guess. So this is because we want to go ahead and start treatment and not wait 24 or 72 hours to get lab reports back, right? You don't want to wait. So what's prophylactic then? So prophylactic is taking an antibiotic, trying to prevent infection. And so if you were working in the emergency room and someone with anthrax came in and you were treating them, you were exposed to anthrax. We would give you Cipro immediately, prophylactically, to try to prevent you from becoming infected. Okay, we don't know if you got infected. We know you were exposed, but we don't want you to get sick. Okay, are these things making sense? One more point about empiric therapy. So you start a drug assuming the patient has whatever bacteria based on the body system and et cetera. When you get the culture and sensitivity report back, it might tell you you were on the wrong track and you have to change antibiotics. The nurse is typically the first person to see those culture and sensitivity reports return to the patient's chart. And so it would be your job to look at that when those reports come back to make sure the patient's on the correct antibiotic. And if not, it's your job to call and get that changed to something else. Okay? So when are you going to look for culture and sensitivity reports? Between 24 and 72 hours. You get a preliminary report at 24 hours, a preliminary report at 48 hours. Those are the ones that tell you what the bacteria look like. You know, cocci chains, whatever, gram-negative. And then at 72 hours, it says it was Staph aureus, and it was sensitive to vancomycin and whatever else. Okay?
What is the term for the 2 hours? Or is it another preliminary?
It's a complete report. Yeah. Question?
So if it's sensitive to the antibiotic, we can't give that antibiotic?
Yeah, so you'll go ahead and continue it and just, go about business as normal. But if it's not the right one, you make a phone call. Okay? Make sense? So as we get into antimicrobials, you should know the difference in names. So an antibiotic is drugs derived from organisms, right? Antimicrobials is more specific. It could be under the umbrella of antimicrobials. It could be antibacterial or antiviral or antifungal. Right, and so when you got your culture and sensitivity report, if it told you that it grew a fungus, but your patient's on an antibacterial, you would know to call a physician and make a change, right? Another thing, a couple of terms that go with antibiotics are bactericidal and bacteriostatic. So if you're bactericidal, it actively destroys the organism. And when we get into antibiotics, we'll clarify which are which. And bacteriostatic means it doesn't kill the bacteria, but it stops it from reproducing. Okay, so you're controlling those bacteria that are there. They'll die off their normal lifespan, but they can't keep reproducing. A couple of other classifications are broad or narrow spectrum. Narrow spectrum is typically a better choice in terms of antibiotic resistance, right? We don't want to give a broad spectrum antibiotic if we know probably what that is or what bacteria we're fighting. The problem with giving the broad spectrum when you can use a narrow spectrum is that eventually a lot of bacteria within our community will be exposed to a lot of different antibiotics and will get more and more resistance. So we want to use narrow spectrum as much as possible, and especially for mild infections, and save our broad spectrums for when we're not sure what we're dealing with and when we're having very severe infections. Some drugs are classified according to the generation, particularly the antibiotics called cephalosporins. So cephalosporins have 4 generations. So the first generation was when we discovered it, and then later versions, the drug becomes more effective, less side effects, or more easily administered. Okay, so that's what we mean. So it doesn't necessarily mean it's a better choice for the bacteria. It means the patient will maybe tolerate it better. We're not going to go over these mode of actions because you're going to see that with each individual antibiotic as we go through them. So we won't need to do that right now.